Well, thanks again to everyone who's hopped on to join us today. Uh, my name is Alex Mitchell. I'm a marketing communications manager with the Lighthouse Lab Services marketing team, and I'm going to be serving as your host for today's webinar. Today, we're going to be speaking about how to get in network and improve payer contract negotiations. This is always a hot topic in an ever evolving landscape, and we're really excited to bring you three great experts from our team here today. Um, Let me start with some introductions here. First, we're going to have Brian Burns, our Vice President of Managed Care Strategy. Brian is a seasoned managed care executive who worked for more than 33 years with Prudential Healthcare, Blue Cross Blue Shield of Kansas City, and Blue Cross Blue Shield of Louisiana. He provides senior executive oversight of provider networks, including outpatient reference lab network design and reimbursement strategies. He also specializes in offering insight into all medical policies, accreditation, health and wellness programs, and chronic care management programs that are all dependent on laboratory data. We also have Brennan Burns, our Vice President of Payer Strategy. Brennan is an experienced contracting manager who previously served with managed care and outpatient lab contracting with Blue Cross Blue Shield of Kansas City, Blue Cross Blue Shield of Texas, and Humana. His expert insight helps labs appeal to narrow networks and improve their overall contracting position when negotiating with private and government payers. And then finally, to provide some supplementary information, we have Ann Lambrix, our Vice President of the RCM Solutions Division, who also oversees payer strategy. Ann serves as I just said, our VP of RCM Consulting, heading up our day-to-day operations. With more than 20 years in the medical insurance and billing industry experience, she provides an insightful analysis of revenue cycle and payer trends impacting reimbursement. And Ms. Lambrix holds an MSJ in Health and Hospital Law. She is a veteran of our webinars, so any of you who have previously joined us are likely well versed with Ann's knowledge and expertise. And we want to thank all three of our speakers for joining us today. Just going to touch on a few housekeeping items really quickly. If you're having any issues with lag or buffering, you can close apps you have running in the background to improve that. We will be recording this webinar. Everyone will receive a copy likely later this afternoon once that recording is available. It will go directly to the email address that you registered under, so no need to reach out to us to ask for that. You can also grab a copy of today's slides under the handouts section. Those are available for download, and we have a little bit of supplementary information available about our RCM and payer strategy teams. So feel free to check that out as well. There's no need to wait until the end to ask us questions. If you have those, you can go ahead and pop those in the Q&A box, and we'll move those over and vet them for a Q&A portion at the end. If you drop those in the chat section by mistake, we can move those over to Q&A as well. And we're going to run a few polls during the webinar. Those are mostly just for engagement and to get a better sense of some of the pain points our audience are dealing with. You are free to ignore those when they pop up if you don't want to participate, but you can just provide a quick answer as well and move on. Briefly, just a little bit of background about Lighthouse Lab Services. We hold these monthly webinars for free, and we provide a host of services to the medical laboratory community, and that's the way that we're able to promote these events. But we are the nation's leading and most trusted end-to-end full-service medical lab consulting and recruiting firm. Whether you're looking for a way to start your lab or grow your current business, we offer a way to accelerate your success. We can assist with lab director placements, temporary and permanent recruiting and staffing. We've built more than 300 laboratories across the country and have a team of more than 150 medical laboratory professionals. And so we'd be happy to discuss any pain points you had that are unrelated to RCM or payer strategy if you'd like to reach out to us, and there will be several opportunities to do so before the end of this webinar today. And with that, I'm going to go ahead and turn things over to Ann Lambrix to talk a little bit more about the current landscape and how our teams help our clients navigate it.
Thanks, Alex. I'm really excited about this topic today, especially with the current landscape, and really looking forward to getting some insight from Brian and Brennan. For those that are new to our webinars, or even those that have our clients or know of Lighthouse, just a quick overview. We work with laboratories and specialty groups across the country, working with their various billing entities, managed care companies, really trying to identify again opportunities within the revenue cycle to improve that revenue cycle, make sure processes are smooth, and then most importantly for today's topic, make sure you're getting paid what you should be getting paid. Looking at contracts, revenue, reimbursement strategy with insurance plans. We have our payer strategy team who is our specialist in that payer contracting, enrollments, and negotiating for all provider types. Really, again, excited to hear what they have to say. And I just kind of wanted to discuss the current landscape. Why are we talking about this? Why is this an important topic? Over the last several years, I've been doing this for a long time. But over the last several years, we've found that it's becoming increasingly hard to get, I would say, reasonable reimbursement from insurance plans. Labs have encountered narrow networks or closed networks, so it's difficult to get into a payer. And if you are able to get into a payer, get reasonable reimbursement. This several factors can be contributed to this. We've seen the No Surprises Act be put into law federally, with various states implementing their type of No Surprises Act throughout the country. Again, narrow networks, limiting access. We've got price transparency laws. Increasingly, especially I would say during and after the pandemic, labs and groups are more apt to have concerns over public and client relations. So making sure that we're in network because we don't want to have the patient or the client get a large bill. So there's a lot of different things that are happening, and why this is a very important topic today. This is the number one issue I would say is when we come to, when a client comes to us to review revenue is, they're wanting to grow and expand. They want to expand their testing within a market. And reimbursement obviously is extremely important as they grow their business, especially as we see again costs rising and reimbursement going down. We see increased denials, we see administrative burden, and so contracts and understanding contracts and access into the various markets are really important. So, with that being said, I will kick it off to Brian to get this topic underway.
Thank you, Anne. And I think I'm on. So I want to talk about the current payer network landscape just to level set. We'll go through 4 or 5 things, and then we'll go to the next slide of appealing to those closed or narrow networks and how you might be best positioned to get in them. And we'll give you a couple of examples as best we can. So when we talk about the current payer landscape, I just kept it simple as HMOs versus PPOs. Most of the United States is in a PPO. Didn't always used to be that way, but today most Americans are in some form of PPO or another. Most insurance coverage is purchased through a group employer contract. So your employer purchases the insurance for you. They typically offer 2 or 3 options, like maybe an HMO, a large PPO, and a small PPO. But nonetheless, most US folks are in a PPO, and there are hundreds of each. So it definitely gets confusing. Some of the networks have fancy prefixes, and some of them have fancy suffixes. And from my payer perspective, the 33 years I lumbered through the 2 Blue Cross plans and Prudential, the payers do try to get creative with those prefixes and suffixes, and they're worth noting. If you see a plan called HMO Select, for example, you pretty much know that that's going to be a smaller HMO. There's probably a broader HMO, but when they use the word select, it most likely means it's going to be an even smaller HMO, which means fewer hospitals, fewer hospital owned physicians, etc. Probably also fewer labs. And likewise, they have some that have fancy suffixes. So you just look for that, and that will help debug a little bit what kind of HMO plan it is or PPO plan it is and what those networks will look like. Some other things to know relative to HMO and PPO is these networks can open and close at the payer's will. So again, when I was in the payer seat, we literally could have a meeting. It might last, we might think about it for a week or two, the pros and cons of opening a lab network or closing a lab network or opening a chiropractic network or closing a chiropractic network. There's really, what I wanted to share with you is there's no real state approval for that. It's a business decision. Now, I know there are access standards. Every state has access standards, but they're miserably easy to meet. So that seldom comes into play. So an open network basically means you can get credentialed, the network's open. You're most likely going to take the prevailing fee schedule, which will be some sort of, it'll be expressed in some sort of percentage of Medicare. And then closed networks mean just that the network is closed, but there's always an asterisk to that. And when Brennan and I work with labs, we try to put together a value proposition, working with the lab, working particularly with the clinicians at the lab to highlight those tests or services that are unique that would otherwise, that could get them into the network when it would otherwise be closed. The other thing to realize is as healthcare continues to spiral upward in an unsustainable way, the lab benefit managers have become more prominent. And the big one out there is Avalon Healthcare. LBM, a lab benefit manager, they sit in between, basically they sit in between the lab and the payer. And they're doing prior auth on lab services prior to the claim getting to the payer. In some cases, they run the network. So they determine who's in the network and who's not. We all know the two big elephants in the room, the two big national labs, Quest and LabCorp. They have massive scale. We are very, very familiar with them, and they are dominant. But nonetheless, we still have had great success getting independent labs into payer networks when Quest and LabCorp are sitting in there as well. And then in terms of payer type, there are lots of different payer types out there. Just from a 101 perspective, clearly there's Medicare, which is the federally funded program. Then there's Medicare Advantage, which is the managed care component of Medicare. Given that there are over 10,000 Americans turning age 65 every day, the commercial payers for sure are looking to get into Medicare Advantage, or they're already there, because that is the baby boomer population heading in that direction, and that's where the business is going. And then like I said before, we have a lot of commercial plans out there. There are the HMOs that we talked about, the PPOs. Now, the PPOs with the Accountable Care Act, also known as Obamacare, there are on-exchange PPOs, the metallics, y'all remember, the gold, the silver, the bronze. Well, you also have off-exchange PPO products. So that would be 6 right there. You have point of service products. You have EPOs, which are basically a PPO lookalike. I think they're filed as an HMO, but they have a PPO construct to them where there's no out-of-network benefits. So there are a lot of plans out there. They have a lot of prefixes and suffixes. Some are open, some are closed. And then we have the intermediary, like I said, the Avalons out there. The typical reimbursement methodology for lab is a fee schedule. The fee schedule oftentimes is proprietary. In my experience, we use CMS. We use the CMS Medicare fee schedule as a guidepost. So we would basically say that fee schedule is a 1.0. And then it was a matter of, well, in our market, we're not competing against Medicare. We're competing against Aetna, United, Cigna, and Humana. What are they paying? What do we think they're paying? And that's how you get below Medicare pricing. The Medicare fee schedule itself is a guidepost, and the commercial payers go underneath it in a way to remain competitive as they compete against each other. I hope that makes sense. And then, of course, there's compression here. The compression is, the recent news. I mean, Humana Medicare Advantage lost a lot of money. Some of the big commercial payers have lost money. Other commercial payers have made money. But in the lab space, compression, fee schedule compression does come into play. And some compression can be doing nothing. So in other words, if we would leave a fee schedule the same rates for 3 years, I would argue that's compression because inflation's gone up for 3 years and we didn't make an adjustment. In terms of out-of-network issues, Ann mentioned the No Surprises Act. That's a that's a game changer. We'll come back to that in a minute. On an out-of-network basis, there are all sorts of methodologies payers use to process claims. So you have that variation, and I think it drives RCMs and billing companies crazy. The other thing about out-of-network, so when you're not in network with an HMO or a PPO, I would think you can expect your accounts receivable to increase as out-of-pocket expenses increase. So what's not written there is in-network, and that's what we prefer. In-network may have a lower reimbursement rate. That's true, but you're going to have advantage and you're going to be able to access the captive members of that health plan. So for example, Blue Cross of Texas has 14 million members. I would say that's 14 million potential customers of your lab. Now, if you're, just in Houston and maybe Galveston or the outskirts of Houston, how does that really work for Lubbock, Texas, or Austin, which are further away? That's true, but a lot of labs have multi locations, and they have far-ranging marketing plans and provider relations representatives that are out there trying to secure those referral patterns. You look at Blue Cross of Michigan has 6 million members. Care First, which those are our friends in Maryland, DC, and Northern Virginia. Care First is 5 million members. So those are in-network potential customers as opposed to thinking about out-of-network and who might trickle to your lab that way. So how can you approach this landscape to achieve your contracting goals? Well, what we do when we sit down with you, we ask this, what are your contracting goals? What are your objectives? What's your location? What does your test menu look like? And go through that. What are your strengths in that regard? Do you have relationships? Do you already have utilization in that area that you can bring to bear pretty much on spot once an in-network contract is landed? And then, I was at a conference earlier this week and talking to some folks. There are hundreds and hundreds of alternate payment models out there. They're in the form of accountable care organizations. They're in the form of clinically integrated networks. On the ACO side, there are about 500 of them on the Medicare side alone, and 1,600 of them on the commercial side. And the most, where most of the ACOs are the most populous states. So California, Maryland, Texas, Florida, New York, those are the top 5 that have ACOs. These ACO constructs are ecosystems of healthcare providers that cover the whole waterfront, including lab. And so breaking into those entities can be a potential strategy to become the preferred lab for that set of providers. So with that, I will turn the page and talk about the appealing to closed networks. I'm going to kick this off, and then Brennan is going to take it from there. You can see about the 4th bullet down, these local and regional organizations that show commitment to quality. These are all risk-bearing entities. The ACOs, the patient-centered medical homes, and the SINs, we just call them SINs, clinically integrated networks. Um, those organizations typically have downside risk with the payers. The risk might not be symmetrical like the old days. So, in other words, it would be a 5% upside risk and a 5% downside risk. That would be symmetrical. Today, it might be a 5% upside and a 2% downside. As payers work with providers to get them on the value-based care spectrum, they'll do an symptom or asymmetrical bonus program. With that, I want to pause for a minute and let Brendan jump in on appealing to these closed or otherwise narrow networks. Did we lose Brendan?
Hey, Brennan, we can see your mic is on, but I'm not able to hear you right now if you want to try to troubleshoot that really quickly. Brian, do you want to maybe try to take this one? Well,
Yeah, absolutely. So we had a client. Blue Cross of Oklahoma, very difficult. It's a closed network, but we have a lab that we had a client, had them for a long time, met all their needs. They particularly catered to the tribal nation, the Indian nation, and so Oklahoma was a closed network, but we put together a value prop for this lab to specifically get them added to the network, and that was a success. Another one down south, we had a dermatology lab. They had a melanoma test, and they were the only lab on the planet, as I say, that could bill a certain code. And we were able to work with Blue Cross Louisiana to help, let's say, review that medical policy to A, cover it, and B, allow the lab in network. And that was a second good one. There was one in Georgia. I can't remember exactly the specifics on that one. I think it had to do with the test menu. Blue Cross of Georgia is part of Anthem. Everyone knows Blue Cross as Anthem, but it's also been recoined as Elevance. That's 13 Blue Cross states, and Georgia is one of those 13 states. And we were able to pry a lab into the Georgia network based on expansive test menu that added value to the network. There are some states here obtain prominent physician referral patterns. That's a biggie. So there can be large multi-specialty physician practices in any of your locations, wherever your lab is located. And if you have a provider network marketing machine, or someone that can make outreach to those large physician practices and garner their referral patterns and get them to help you basically petition the payer to allowing your lab in network because you're doing such great work, you have great turnaround time, and you're providing a great service for those prominent physicians. We've seen that work as well. So I think I touched on most of those things, the special demographic.
Real quick, Brian, I know I said that we'd do questions at the end, but we have one that's received a few votes already. And since Brennan was having a few technical issues, I thought we might touch on it here.
Okay.
But we have one viewer said that their credentialing company is now suggesting letters from referring physicians that commend and advocate for their laboratory. Is that a strategy that you've seen have some success in the past?
I have. I've seen it in multiple different areas. I mean, if I can just off-road for a second, with CVS and Walgreens across the country, they're just about on every street corner across the street from each other. They would have huge mailing campaigns against each other. So if CVS was in the network and Walgreens wasn't, then Walgreens would get everyone that had foot traffic, every customer that came in their store, sign a little postcard and they would then bombard the local Blue Cross office. That happened to me in Kansas City. And so we eventually let Walgreens in. Those campaigns work, and I would suggest that if you're going to do that, send, have those letters or postcards sent into the marketing area of a payer. So if it goes to the network, if it goes to the network team, they're going to be like, "Yeah, we know it. You're not in the network, sorry." But if it goes in through marketing, who's very in tune with revenue, very in tune with customers, very in tune with member abrasion and member dissatisfaction. Not that the network folks are not, but I'm just suggesting if they go, if I have my choice of sending, I think I would favor send them in to the marketing folks or the president of the plan, the top execs, and put pressure on. I think that definitely can help.
All right, great. Thanks for touching on that. Are we ready to move to the next slide?
Yes.
Okay. I think we're going to have Ann speak on
Yeah.
this one.
So yeah, the pathologists. So we work with several pathology groups across the U.S., and a lot of them are hospital based. Some of them are independent lab, but with hospital based. Again, I feel that there are some unique opportunities to position yourself to negotiate with these payers. And some of those strategies is again looking at your utilization of the plan. So the hospital, if the hospital is participating with the payer, and leveraging that relationship with the hospital and leveraging that with the payer. They're really, I feel, Brian, I'm going to call on you here, but I feel that pathology groups that have that relationship with their hospitals have a better leverage with those payers, because really ultimately the payer, especially if there's high utilization for their member population with those facilities, they don't want those pathology groups to be out of network. So, getting the hospital to intervene on your behalf or being part of the negotiation, I see sometimes is very successful, because again, you have them at the table to ensure that the number one, the rates are reasonable, and number two, that the payer is working with you. Have you seen that as well, Brian?
Absolutely. And just to back up for a second, there are four hospital-based specialty types.
Hmm.
There's radiology, anesthesia, pathology, and ER. Today we're just talking about the pathologists, but just wanted to throw those other
Right.
three out. They do hold a unique opportunity, like Ann said. They've been granted that special opportunity by the hospital. And if you're a Blue Cross plan, which is most likely the largest payer in any given market that it's participating in, then most likely that hospital is also a client of theirs. So there's some, and maybe even the pathology group is a client of Blue Cross. So unraveling that just a little bit to add pressure, that kind of goes into the value prop, just what angles we take to try to get better rates, or you know, maybe fewer prior authorization requests. But the hospital-based physicians have a special place in the network for reimbursement. Their reimbursement levels tend to be higher, and you've got that special relationship. You're in the payer's network, and you have that special relationship with the payer, and most likely the payer insures the hospital.
Right. I found that I think that the No Surprises Act hit especially hard with those specialty groups, hospital based. Again, way back before NSA, we were able to leverage being out of network as part of that negotiation strategy. So, being able to balance bill patients, being able to walk away from the lower proposed reimbursement and say, I want this, and if I don't get this, I'm walking away, and we'll bill your patients, we'll bill your members. And so that
Right.
was a strategy. And No Surprises, that kind of took took that away. And so, that's where again I feel that that unique opportunity is it although that is probably not a favorable strategy anymore, I still think that specialty groups, because they are in that relationship with the hospital, they have those advantages to be able to leverage that relationship with the payer and work closely with their hospital that we want to negotiate with this payer. The payer is unwilling to negotiate with us, and so our only option is to go out of network. So we need your help, because again, I go back to the hospital, nor does the payer really want, especially if there's high utilization with that plan for their members. They don't want the group to be out of network. So, but that's where again I see the No Surprises Act has really put a crux in our negotiation strategy for hospital based.
The only thing I would add is the way the payers design the benefit plan designs, the member out of pocket, out of network is probably at least 10% greater, probably more like 20%. There are state regulations on how far that differential can be and still be considered an insurance product. Um, but still, they have that higher out of pocket expense on an out of network basis, even though the claim is getting processed at the
Right.
some median point of the in network rate.
Right.
Yeah.
Agreed. And so that gets into in my, going back to my initial discussion about, your public relation, your patient relationship, pathologists and your radiologists, your those specialty physicians within the hospital, that's something to again look at your deductible trends and how that out of network impacts your reimbursement long term, and really being able to develop a good pro forma on whether in or out of network makes sense for you, especially if you're out of network and the patient ends up being the patient becomes the primary payer for several months if they have an high out of network out of pocket expense. Independent lab, Brian, I think that again, when we talk about labs versus a hospital based specialty group, there's some unique circumstances where when negotiating a contract, it is more, uh, I would say, difficult to negotiate for an independent lab versus a hospital based. When I talk about negotiating, it's not necessarily getting a contract, but if the reimbursement that is offered is lower than, let's say, Medicare, what are some of the things that we can do to, negotiate up, increase that reimbursement?
Yeah, this is a great question. We get this probably every second or third phone call when we talk to a prospect. And what I say is, independent labs have a real value to the network. There are places where Quest and LabCorp don't want to be, where an independent lab can fill a void, can offer more unique, high touch, white glove, if you will, type service to its physicians. But honestly, in year one, you're pretty much going to take the fee schedule, the prevailing fee schedule that the payer is offering. It's kind of a take it or leave it. And those reimbursement rates on the one end is like 50% of Medicare. Really hate to say that out loud, but it's true. And then we've seen plans that reimburse, these are in-network contracts at 110%. And so our recommendation is, unless we're going to position something unique, proprietary up front, then the next best thing is to get a network at the prevailing rates, be a good actor, have excellent turnaround time. Every payer has what's called a special investigations unit, an SIU for short. You do not want to be in the SIU unit because you'll just languish there. I sat on those committees, and I'm not suggesting any of you would be. I'm just saying, in terms of a strategy, get in network and just be the best provider you can. And then in the out years, when you have utilization, and you've got a track record, you've not been involved in any investigations from the payer, you've got great utilization, you've got some referring docs that might even write a couple glowing letters on your behalf to the health plan, to the payer, then it's a time, then I think you've got some leverage to try to negotiate an increase. And what would an increase look like? It wouldn't be 10%. Um, payers are payers think more. Payers margins, first of all, are 2% or less. We used to call them grocery store margins, although no one really felt sorry for the insurance companies. But we always had a target of 2% profit, period. And very, very seldom in all those years I worked did we ever meet 2%. I know one year we did because there was an accounting rule change, but that wasn't because of operations. So I think a fair lab increase, even if we could stair step it over a couple of years of like 2.5%, 3%, 5%, or some sort of graduated type increase like that, I think might be palatable. Again, in the out years when you have good physician testimonials and you have great track record on utilization and that kind of thing.
I think we're good to go to the next slide, Alex.
Okay.
Yeah, so this slide here, this is a collection of other things to consider. And I'll start with the risk-based agreements. You can go out to the CMS website. I think it's actually cmmi.gov or something like that. But there are a whole host of quality programs that the federal government is running or will be running. So it just gives you a sense that this isn't going away. The old days of just fee for service are gone. The market is going to fee for value. It's what we call fee for value. And how you get to fee for value is through these risk-based agreements. These quality programs like Blue Cross of Michigan, this is a well-known one. But honestly, I think every payer has some sort of quality program or another. And the reason is because every payer is accredited by either URAC or NCQA. Hospital accreditation is JCO. From a health insurance payer perspective, their accreditation is either URAC or NCQA. Some do both, which a lot of us think is overkill. Just pick one, NCQA or URAC. And as a key pillar of that accreditation would be these quality programs. So it's how to increase diabetic retinal exams or DREs. How do we, on the lab side, and there are probably 5 or 7 lab measures that payers need for these programs. A1Cs is one. I meant to have my list in front of me. But there are 5 or 7 really, really important HEDIS measures that go into the quality programs that the payers use for their accreditation. And so talking that talk and trying to get in any of these risk-based programs that you can help support that, you would need electronic connectivity, but I don't think that's the highest hurdle to get to. But these bonus programs are in every payer organization. And they're funded by the payers, and it's bonus money for the providers. And so again, if you can get in there and be that trusted laboratorian to help with patients, I think it's a good thing. I was in this conversation yesterday where there are some practices, physician practices, that are putting pharmacists in the practice. So like a PharmD, and they're starting to think about like a lab tech or some sort of level laboratorian that would help the larger practices with the results, the test results, and the disease and the condition and just the whole treatment plan. And that's kind of new. I think it's really exciting. I know pharma has been at it for probably 6 or 7 years, where there are some practices that will only allow the pharmacist to do the prescription because the docs are in some sort of bonus program with with the payers, and the PharmDs know pharmacy the best. So that's an idea for you there. I definitely see the payer as a client. If you can put that through your glasses, and look through your glasses as the payer as a client, that might help. As I think that might help in terms of what can you do for them, what can you do to help them, whether it's the HEDIS results, whether it's interpreting lab results or getting the lab results back faster, things like that. That might put you in a better position. These appeal letters, every claim, it's a state regulated. Every state has a Department of Insurance. When I was at Blue Cross of Kansas City, the state line ran right through Kansas City, so we got the joy of working with Kansas in Topeka, and then in Missouri, Columbia. And so every payer has to deal with the state Department of Insurance, and the DOI is a very member consumer friendly, I was going to say institution, but you know what I mean. They're an advocate. The DOI is definitely a member advocate. So writing thoughtful appeal letters to the payer, they go unanswered. If you don't get a response you want, then I think you take that letter and take it up a notch and include it in your appeal letter to the state for sure. This last bullet, state utilization, is always an important consideration. What this talks about is there are some payers that require the lab, that brick and mortar in the state, we call that. So Florida is a good example. They require brick and mortar. So you say, okay, we have a lab in Orlando, and then they come back and say, oh, but our network's closed, no network needs. It's like, all right. So it's kind of tricky there. In other states, what they're really trying to do is promote in-state business. And so they'll want brick and mortar in that particular state. The providers usually utilizing those in-network labs, utilizing the in-network payer organization, and that whole kind of altruism, if you will. So state utilization is always a consideration. It doesn't mean a California lab can't get into Louisiana, or a North Carolina lab can't get into Care First in Maryland. All I'm saying is state utilization can be a really important consideration. And then the last.
Brian, I see this a lot, and so I think that that's a really important topic to, again, drive home. It really depends on the state, and I would say it depends on your testing too. So, understanding, and I think you talked about this a couple slides ago about your the test offering that you have. If you offer, your run-of-the-mill testing, again, going into that, the network is closed. It's sometimes difficult, especially if you're trying to get in out of state, to get a contract with the payer when you're not offering anything unique that they can't find in state.
Right.
Oh, okay. I think if we're done with this slide, we're gonna flip over here, since we're getting near the end, to a summary. Prior to that summary from Brian, and before we hop into Q&A, just in case anybody has to run here but wants to follow up with our speakers or with us for more information, as part of an offer for everyone on today's call, we are extending an offer for a free hour of payer strategy consulting. You'll have a chance to talk with Brian and Brennan and discuss your pain points, see if we could be of assistance. If you'd like to learn more or request that offer, go ahead and open up that contact form, fill that out, and we'll be in touch with you. You can also email us after this event, and we'll follow up with you as well. I'm going to turn it back over to Brian to wrap things up before we hop into Q&A.
Okay, so this is the money slide. This is the big money shot. We tried to get all the big points on one slide at the end. So first things first, current payer networks are increasingly competitive for multiple reasons. Some are shrinking, some are expanding, but the fee schedule's going down. And so it's just very competitive out there when it comes to really any provider type, but in particular, I think lab reimbursement varies, and more payer utilization management should be expected. So I gave you the range of reimbursement of 50% of Medicare up to about 110%. And the payer utilization management, that's the prior authorization arm that sits in between the provider and the payer. And I don't want you to think that the payers are singling out lab per se, because there are radiology benefit managers that jump in the middle of the MRI center and the payer, and they're prior authorizing the MRIs, the MRAs, the PETs, and the CT scans. There are SBMs for surgery. There are TBMs for therapy, so PTO, TST. So these LBMs, the lab benefit managers, is just another way for the payers to help manage that line on their medical expense budget. So just be on the lookout for that. I'm suggesting we could see more of it. Go-to-market strategy should be comprehensive. Not, I mean, we should talk about it, but you want to be as comprehensive and as expansive as possible to try to get in these tricky networks. And then variations exist in the contracting, like Ann and I talked, relative to pathologists slash specialists and labs. So I think there's still good hope and opportunity there. It's just a matter of how do we best position your lab and the talking points, and make that best value prop and offer to the payers. So with that, that's the presentation, and I really appreciate your time. And I've seen some questions going through the margin on the screen, so I'll turn it back over to Alex.
Yeah, thank you, Brian, and too. It was really great information, really thorough, and I hope the audience was able to take a lot from this today. We've got about 5 to 10 minutes that we're going to hop into Q&A here. There may be a few questions that are better addressed offline. So again, if we don't get a chance to touch on your question, I'm going to push this contact form one more time. If you want to go ahead and open that up. If we don't get a chance to touch on what you're asking about today, please follow up with us and we'll make sure that we make some time to do so. For our first question, we have speaking about toxicology claims and how they interact with the No Surprises Act. This lab contests the validity of their adjustments that they're seeing, and don't believe that their toxicology claims should be falling under the purview of the No Surprises Act. And is that anything that you've seen in particular, toxicology labs struggling with that?
Yeah, I would have to. I mean, I would suggest that that individual follow up with me directly. There's a myriad of questions that I have for you, and as far as adjustments that you're receiving, and again, how the NSA would be applicable to you. So, um, no Surprises Act, I would say, it depends on, again, who you talk to and how you read the law. But there is some requirement. I would say that if the laboratory is out of network, I would not be balance billing patients, meaning the difference between the billed charge and the allowed amount. That is really important to understand. And so if you're doing that, that's something that we could talk through on why that's just not industry norm. As far as the payer allowing an out of network rate, again, that goes back to whether or not if you're out of network with the payer. It really has nothing to do with no surprises. It's just that reasonable and customary rate that the payer is determining, and you will need to accept. You can't, again, going back to, you can't balance bill the patient, but would look forward to that discussion further with that individual.
Thank you, Ann. This is a question that came in early. This individual has a practice that has a physician-owned lab, so an in-house lab, and one of the insurance companies that had previously always reimbursed sent a letter saying that they will no longer be reimbursing for in-house laboratories. They've been working with this
Hmm.
payer for 20 years. Can you provide some insight into why that might happen?
I'll take this, Brian, really quick, and then maybe you can add some more insight. But we're seeing more and more payers adopt what they call a in-office lab exception rule. And so you see this especially with your managed Medicaid plans. And I know Humana also has their national lab table. And so, that is again a way that the payers control their cost as well as their networks, and they have their exclusive agreements with your LabCorp Quest, where they want certain tests to go through. You're not allowed to run them. They will not pay for you to run it through the in-office lab. There are some exceptions to those, and again, I would say it would be on their lab table. So we do see that. Brian, anything as far as they've been working with this payer for 20 years, and now they're no longer paying for these tests. They're not on the exception for their lab table. Any thoughts there?
Yeah, I think the first thing that excuse me comes to my mind is I would want to have a sit down with somebody at that payer, not in an adversarial way, but just to better understand where they're coming from. What changed? If again, if it's the HEDIS data, if it's getting the the metrics, the biometrics, um, then that might be a hurdle that you talk to overcome, as opposed to just being dropped out. Um, I gotta believe, it's probably part money, but also the lab tests themselves are important, but lab values drive 70% of diagnoses. And inside a payer organization, the lab values and pharmacy data at the NDC level are far and away the two most critical data elements needed to drive the clinical algorithms that drive the population health programs at a payer. So it's either, I can only think of two things. It's either um, someone is trying to save a couple nickels and saying you can't have any in-house labs anymore, which I think would be very short-sighted, or it has something to do with missing lab values. And so it's really just having that conversation with the provider rep or the provider manager, the network manager at the payer, to try to have a conversation about what does this mean and why now. And we've been such a good actor, good player, good provider for you for 20 years, 2 decades. Surely we can talk about it. I mean, that's how I would approach it. I'd try to be very collegial about it.
Thank you, Brian and Ann. That's great insight there. I think we're going to take about two more here before we hop off. Um, this individual's talking about labs who are getting flat out denied for large number of target panels. And I know that that's a utilization issue that has given folks a lot of trouble in recent months and years. But what would you recommend here, for like an 87507 or an 87633, especially considering that changing physician behavior with ordering patterns is so difficult?
Yeah, I think again, I saw this question, and I would advise to reach out to me directly. I think that this is a sidebar conversation about this type of billing that it really is. I don't think in relation to contracts.
All right, thanks, Sam. One more that we're going to take here. Let me open up the list here. What was I looking for? Not sure if this is something that we could touch on, Anne, but how do hospital labs get paid for test orders outside of their hospital tax ID? Would
So we have a lot of, so it's again outside their tax ID. The hospital may contract with a pathology group that would do outreach. And so the outreach would be, let's say it would be brought in through the hospital lab, and then the pathology group would purchase the technical component, or again, they would work with another independent lab to again produce that technical, and then the pathologist would do the read. But that's typically what we see. And so dependent on the payer, again, it would be a separate tax ID from the hospital, and all of those claims would run through that pathologist tax ID. I think
Perfect.
that answers the question. Again, if not, reach out to me directly. We have lots of groups that do outreach business.
Yep. Just in case, we're going to wrap up here and give everybody back a few minutes of their hour. If you did not get a chance to get your question addressed or want to follow up with us now, there's that form one more time that you can do so. Please take advantage of that if you have any lingering questions or are wondering if our services could be assistance to you. Otherwise, I'm going to say thank you again to Brian, Brennan, and Ann for joining us today, providing their expert insight. It was really valuable, a very active webinar. Thank you to everybody who joined us and provided questions. It's always great to see that engagement. The recording should be available later this afternoon, and if not, it'll be in your inbox first thing in the morning. So thanks again to everyone, and enjoy the rest of your day.